Frederick Douglass had said, "It is easier to build strong children than to repair broken men." The statement powerfully highlights importance of investing in our children to help them become good adults. And the first and foremost thing that we can ensure for our children is good health that can help grow a sound body and sound mind. However, India faces a serious crisis when it comes to the health of our children. And at the core of it lies the widespread problem of malnutrition. Malnutrition among our children. That is the theme of the day which we are going to discuss. India is a home of the largest number of children in the world, and that unfortunately translates into having maximum number of malnourished children in our country. This is definitely a big impediment in reaching to the SDG goal that the government has committed in the global community. To understand what are the challenges our nation facing when it comes to every 7 decades of independence, and despite the fact that now we are the food surplus country with among the largest producer of most dairy products, fruits and vegetables. Our very distinguished panelists today in the inaugural session of the third day of Bharat Nutrition Week, Dr. Jagmeet Madan, an eminent nutritionist, national president of India Dietetic Association, and is the principal and professor of Department of Food, Nutrition and Dietetics at Sir Vithaldas Thackeray College of Home Science, SNDT Women's University in Mumbai. She has been an avid researcher, and her area of interest include childhood obesity, body composition of school-going children, adolescents, and its relationship with the diet and lifestyle factors. And also she has done remarkable work in the area of macronutrient sufficiency among Indian population and its role in public health outcomes. We also have with us Dr. A. Lakshmaya, scientist and head public health ICMR, National Institute of Nutrition. Dr. Lakshmaya is an epidemiologist and public health nutrition specialist in the Division of Community Studies. He has been researching extensively in the areas of public health nutrition. He is the execution in charge for activities of the National Nutrition Monitoring Bureau and serves an advisory committee member in health and nutrition for reputed government bodies like the Department of Science and Technology and Midday Meal Program. We also have with us Dr. Ajay Khera, country representative of Engender Health India. Dr. Khera is one of the most famous name in the area of public health in our country. Dr. Khera has served over a decade as commissioner and public health specialist for reproductive, maternal, newborn child and adolescent health program of Government of India. He has been closely associated with polio eradication and national vaccine policy. He worked as an epidemiologist in the Sultanate of Oman and as a WHO consultant in Myanmar. He also contributed in developing the strategy on early childhood development and quality of care around childbirth. Dr. Khera has been instrumental in completion of India's first ever nationally representative nutrition survey of children and adolescents in India, the Comprehensive National Nutrition Survey, CNNS. The survey is the most robust and was the largest micronutrient survey ever implemented globally. Welcome, Dr. Khera, Dr. Lakshmaya, and Dr. Madan. We also have with us Mr. Ravi Bhatnagar, Director of External Affairs and Partnership, Asia and Middle East of South Asia for Reckitt Benckiser. Ravi is a global public health and global public affairs professional who currently heads the external affairs in RB. He's also among the most influential health communicators in the country and has been the driving force behind some of the most remarkable public health hygiene awareness campaigns such as Dettol Banega Swachh India and Dettol Banega Swachh Bharat, Swasth Bharat. He is also leading another major project of RB Nutrition India program, an innovative digital and artificial intelligence based project which aims to enhance health, hygiene, and nutrition for pregnant women and children and give the best start in the first 1,000 days. We also have with us a very special guest from New York, Dr. Ashish Atreja, Chief Strategy Officer, RX Health, and Associate Professor and Chief Innovative Officer, Medicine, Icahn School of Medicine at Mount Sinai, New York. Dr. Atreja is a healthcare executive and entrepreneur with a board certification in internal medicine, gastroenterology, and clinical informatics. As Chief Innovative Officer, Medicine, he established Sinai App Lab in 2012, which was the first innovation hub within an academic medical center in US to build the test disruptive digital health technology. Dr. Atreja also serves as a scientific founder for Mount Sinai spin out RX Health with a mission to democratize and prescribe digital health globally. So thank you so much, all our speakers, so for our audience to understand and know better about you. I would like to begin today's discussion with and I would like to go to Dr. Ajay Khera first on this. Dr. Khera, you have been involved, for over a decade. You have been very, very extensively working in the area of understanding the malnutrition problem in India, in a manner which was, one of its kind, unique in the. What is the state of nutrition in India, and what are the biggest challenges we are facing as a country? And you, with your expertise, your work, I'm sure you will be able to tell us that what are the larger picture which we need to deal with. Dr. Khera.
Yeah, so first of all, thank you very much, Mr. Kamal Narayan, for the introduction. And greetings to all of you on behalf of the Engender Health. And I will also at the outset like to wish you the best of, Bharat Nutrition Week, a kind of a program which you have initiated. And today, we are talking about malnutrition situation, and we also talking about what are those various interventions which are being put in place in order to address the huge burden of malnutrition. Just to give you a bigger picture, in India, the problem of malnutrition is so huge, and we continue to say that every third child in the country is malnourished. It's a huge problem. Every year, around 25 million children are being born every year. And if we consider up till 5 years of children, which are around 125 million in number, around more than 30% children are undernourished. That's number one situation. And then the second important thing, big picture is that beside undernutrition, there is something called as the anemia. Because anemia and undernutrition, they also move simultaneously. And the problem of anemia is so huge, and the burden is to the extent that every alternate child in the country is anemic. So you can understand the burden. Every third child is undernourished. Every, second child is anemic. So, and these problems of malnutrition, they are all linked with not only with survival, they are also linked with the overall development of a child. Now, as you know that India has an infant mortality rate of around 32, and we're around 8 lakh children die every year. And if we try to do a critical analysis, you will be shocked to know that 50% of the child mortality is in the backdrop of malnutrition. Malnutrition per se may not be killing children, but the backdrop of malnutrition leads to lot of deaths of children, because a child with malnutrition, if gets a bout of diarrhea, child dies. If a child with malnutrition gets a bout of pneumonia, child dies, but the healthy child may not die. So more than 50% of the child mortality is attributed to in the backdrop of undernutrition. And also the anemia situation is so huge, it also is leading to a lot of weakness, inefficiencies in the system. Now, in order to address this huge burden of, the undernutrition and anemia, the government of India, under the able leadership of the Honorable Prime Minister, started a big abhiyan, which is called as the Poshan Abhiyan, and where we have put, ambitious target of reducing the undernutrition by, 2% per year. And if you look at historically, we have been reducing undernutrition by less than 1% per year. So ambitious targets have been kept. Now, in order to, achieve those ambitious targets, something special out of box needs to be done. Now, in order to, what are the actions, which are required to be done? And one of the important thing is, there is a lack of awareness, and lack of awareness is one of the major impediment in terms of addressing the problem of undernutrition. And there is something called as the 1000 day. 1000 day is a critical period, and 1000 day implies, first, the 9 months of the pregnancy, the day the child is conceived, the 9 months of pregnancy, and then we have the rest of the days up till 2 years of age. So these are supposed to be the critical period, because we have seen in India around 20 to 25% children which are born in the country are low birth weight. Now, low birth weight, if the child is born as low birth weight, child will remain undernourished. So if you really want to address the issue of low birth weight, you have to address so-called the 1000 day window. That means quality antenatal care is to be provided. Good food is to be provided during pregnancy. Regular checkup of the pregnant woman has to be carried out. And that's why Government of India has come up with a variety of programs, where we are ensuring, kind of a free checkup of all antenatal mothers. We are ensuring free delivery of the mother. So first 1000 days is really critical in order to address undernutrition. Now, within 1000 days, it is not only the period of antenatal and intrapartum period. The interesting part is, feeding practices. Now, there are a lot of kind of, awareness gaps in the population in terms of understanding the knowledge about the feeding, like breastfeeding. And you'll be shocked to know that only 50% of the mothers in the country are in a position to breastfeed their children. Why? Because they are not fully aware that breastfeeding is such an important intervention which can really help in improving the nutrition level of the children. And to improve breastfeeding practices, there need to be awareness of the mother, and somebody has to support the mother, somebody has to counsel the mother. And there is something called as, we have to protect, the breastfeeding. So there are a number of, critical principles which has to be promoted in order to encourage breastfeeding. And then the third important awareness point, which I want to highlight at this point of time, is something, which is very disturbing in the country, which is leading to huge burden of malnutrition, and that is called as the poor complementary feeding. At 6 months of age, the child has to be started a complementary feeding, and we recently did that, with the reference to the Comprehensive National Nutrition Survey or National Family Health Survey. They indicate that the less than 10% of the mothers are giving right quantity and right quality of the food at the age of 6 months. So complementary feeding is a major challenge in the country. 90% are poorly, doing a complementary feeding. So that means it is not the question of availability of the food. It is more of awareness. Yes, food is important, but beside availability of the food, we also need to be aware of the what kind of food, how much food is to be taken. So these are the two important areas. And the third important area I will like to flag here is, which is also very critical, is in terms of the family size, the interval between the pregnancy, the population, the family spacing. If you have a birth of the children at a very frequent interval, you are going to give birth to a undernourished children. So that means there should be at least a gap of 3 years between the two pregnancies. And the situation in the country as on today is, 50% of the deliveries which are happening in the country, they are happening within a span of less than 3 years. Every alternate pregnancy is happening with a span of less than 3 years. I think we need to promote this practice of, pregnancy interval, promoting birth spacing, promoting family planning for the purpose of spacing, if not as a purpose of population control, but for the purpose of improving nutrition, we have to address this so-called the population and the spacing. And last but not the least is, which is not a big concern, but still an area of concern, something called as, early pregnancy or early marriages. As on today, in India, around 8% pregnancies are happening in, adolescent girls. And you can understand 8 to 10% is a huge number. Out of 25 million births happening, 2.5 million births are happening to women. Actually, baby delivering a baby. So you can understand, if an 18 or a 19-year-old girl is delivering a baby, because she is not mentally mature, she is not physically mature. So I think we need to address the issue of, early marriages and early pregnancy. And I think we need to have a war on this adolescent pregnancy. We should be able to eliminate early pregnancy in the country, So I think these are the big thoughts which I have in mind. And I think these are the issues which we need to address if we really want to improve the health, development, and survival of the children in the country. So with these few words, I stop here, and my best wishes to all of you.
Thank you so much, Dr. Chhera. I believe you are going to stay with us. We can come back after talking.
Sure.
Yeah. Okay. So let me go to. So you broadly, put forward the big numbers, which are really, kind of shocking. Every three out of every 3 children, we have 2 who are malnourished. They are, stunted. We are losing a lot of lives because of the, mostly because of malnutrition, which is largely attributed to that. And then you are highlighting all these aspects of right from, stopping pregnancy at adolescence to, for example, having the right interval between the deliveries, and also the right kind of breastfeeding practices, and also the supplementary food for the kids. So, and this involves so many factors around it. I think it is, a lot of social, economic, and many other aspects, behavioral aspects are involved in this. We will, try to understand that as well. But Dr. Jagmeet Madan, apart from these broad understanding of underweight, stunted, wasted, what are the other, hidden hungers or malnutrition which we are facing in our kids, especially of micronutrients, macronutrients, and how much it is playing a role in the health and their productivity?
So at the outset, I bring greetings from Indian Dietetic Association and Sir Vittal Das Thackeray College of Home Science, SNDT Women's University, Mumbai. Thank you, Integrated Health and Wellbeing Council, for giving this opportunity, and Mr. Kamal. I think right at the beginning, I would congratulate Mr. Khera, especially because as a nutritionist fraternity today, we are very much heartened that, nutrition today is a national will, or optimum nutrition is a national will. And when things trickle from central conviction and belief down the order, I think success is inevitable. So that is where I, first of all, express my gratitude to the national government to have taken nutrition as the center stage agenda in the country, and engage with all stakeholders who are responsible to deliver, nation's well-being, and across the age group, across the socioeconomic strata. To my mind, the most important group which really needs to be addressed is our infants, young children, adolescents, and I would go one step further to say even young adults. So every step has a significance, and every step is interrelated. So what Mr. Khera said, that starting from preconception to the entire stage of pregnancy, to the lactation, to the first, year of child's growth, or first 2 years of child's growth, at every stage, the right kind of nutrition intervention is important, because these things are not compartmentalized. They are all interlinked together. And we all know that any insult done during pregnancy has repercussions in the later stage, starting from early childhood to young children and adolescents. I have been working in the field of child nutrition, infant and child nutrition, for almost more than a decade. And I worked a lot with young children, adolescents. And what is most concerning is that way back in 2008-10, when we did a huge multicentric project, which was spearled by Dr. Anup Mishra, MARG, and we covered more than 10,000 school-going children from government and private school from Mumbai. This I'm talking in the year, 2008 and 10. We found that there is a dual burden of malnutrition. On one side, there is overweight and obesity. On the other side, there is gross undernutrition. But the ironical thing was that at both ends of the spectrum, whether it is high socioeconomic strata or low socioeconomic strata, it was the quality of food which was compromised. And very rightly put up by our eminent panelist, that the basic cause of compromising on the quality was not only the affordability, but the ignorance. And that is where from then onwards, we took this thread forward towards the mandate of nutrition education. We went one step further to identify what is happening internally to these children. And you'll be surprised to know that children with normal BMI, low BMI, carried high body fat percentage. We went one step further to link that with the dietary and lifestyle practices. And again, you'll be heartened to hear that there was a direct correlation between the quality of eating and the body composition which the child has. So today, what we are addressing is not only compromised state of nutrition during pregnancy, during lactation, or during first 1,000 years, but I think what is most alarming is that we have children who are apparently looking healthy, normal, but still carrying a lot of inflammation in the body. And inflammation means excess of body fat, which is getting directly correlated to the eating habits which they have, the kind of lifestyle factors which they are engaged in. I would like to share our recent work where we have screened 1,300 adolescents and young adults in the city of Mumbai, starting from 16 years to 25 years. You will be astonished to hear that more than 30% of these kids are at risk to pre-diabetes. They have hyperinsulinemia already floating within the body. And to look at, these kids are absolutely normal, So what I'm trying to point out is that the problem is really grim, severe. And in addition to undernutrition and overnutrition, what you said is we also have hidden hunger of micronutrient malnutrition. Because very often our attention just focuses around the macronutrients, but I think micronutrient malnutrition is also becoming rampant because it gets compromised with the quality of diet, with the dietary diversity. But the good news is that as a nutritionist, I vouch for a food-based approach. And I talk on behalf of the entire fraternity that we have actually experimented it. And we have used a food-based approach in our recent work. And we have found that just by altering the kind of snack which our adolescents or young adults are consuming over a defined period of time, we can bring about changes in their internal environment. We can bring about a decrease in their body fat. We can bring about a decrease in their inflammatory markers in the body. And, these are very heartening threads which we are getting. So again, as a scientist today, we want to talk evidence-based, facts. So we get these evidence from these little work which we have done. And today, as the National President of Indian Diabetic Association, we are working very closely with the government. And, we are an extremely integral part of the Eat Right India initiative, and are, working at all levels, whether it is creating resources, whether it is reaching out every stakeholder which is
Dr. Madan, I will come. Dr.
And we are working very closely with them.
I will come back to you on more details about how you are trying to actually bring the right interventions to the communities and the people around you. Let me go to Dr. Lakshmaya first. And Dr. Lakshmaya, as Dr. Jagmeet Madan also highlighted that, while we are looking at those, the broad, aspects of undernutrition, the malnutrition among the children, this, ever increasing number of over-nutrished or wrongly nutrished, children, which is around 14 million, I think, obese children we have reported to have in our country. Dr. Lakshmaya, how your institution like NIN is working and ensuring that at all level, not only awareness, but at the policy, but also how we are going to make sure that the right kind of food choices are going to reach to the people, and they are the right kind of food being made available or promoted. What is the role NIN is playing in this?
Thank you for inviting Kamal and other committee members and other experts, especially Professor Jagmeet Madan and Ajay Kera, then other dignitaries. So good morning all of you. So this is actually your topic is the healthy children and healthy nation is a very opted subject. It is a very nice subject, and it is true also, because without health of the children, the nation cannot be healthy, because today children, tomorrow's leaders. So the healthy children is very, very important. As previous speakers already discussed at length about undernutrition and micronutrient malnutrition, and actually I can say that it is a triple burden of disease. India is facing triple burden of disease. One is undernutrition and hidden hunger, then NCDs, non-communicable disease, extensively non-communicable disease prevalence also going on, especially. And in all sections of the population, even we have extensively studied, we have conducted large epidemiological studies on tribal population, rural population, even urban population. And we noted that even among tribal population, the overweight, obesity, and hypertension, even every one fifth of person is suffering from hypertension, even in tribal population. So all this leading to unhealthy population, and the even burden of the even at a country level, the health burden is increasing. So this all to curtain all this unhealthy population, the best choice is we have to take at childhood age itself. And we are living in a vicious cycle of even obesity. Obesity is also a vicious cycle, because even infection is also a vicious cycle. Infection and malnutrition, then obesity is also a vicious cycle, and it starts with childhood. Even several studies also proved that if the presence of overweight obesity during childhood, 77% of children is likely to carry it over in the adulthood. So the better option is we have to prevent it the childhood itself, the overweight obesity. And overweight obesity leading to even several consequences, the battery of consequences. It may lead to insulin resistance, diabetes, hypertension, cardiovascular diseases, and sleep apnea, and several complications. This leading to. But what is the reason? This is the reason could be the unhealthy food habits, because we have done several studies on unhealthy food habits, and and previously, and 10 years back and 10-20 years back, and now we compare to our dietary pattern is totally changed. So we are almost forgotten our traditional diet. So we habituated a modern diet and very unhealthy diet. And a recent survey shows that about 35% of population, at least at least 3 days they are consuming processed food in a week. So that is the scenario of now present consumption of unhealthy diet. So all these reasons, because as Professor Madan also said, and even Kara also said that this is not because of lack of food. This is not because of poverty. All this happen. It is because of ignorance. So the even literate people also illiterate in nutrition knowledge. So that's what every time we used to observe. Even they are literate, but nutrition point of view. So most of the people, they may not know what to eat, what quantity, and what quality of food. These three things are important: quantity, quality, and frequency. So the selection of food is also important. And we have done one beautiful analysis, the intra-family distribution of even foods, intra-family distribution of nutrients, how much calories are distributed within the family, how much vitamins are distributed in the family, how much fat is distributed within the family. And surprisingly, suppose if you undernutrition, if you taken place, if you discuss, and the same energy is meeting parents, energy requirement is meeting in parents, and whereas in children they are not meeting energy. So that we cannot say that parents are eating for the portion of the children, but it is ignorance, because how much they have to feed to the children, how many frequencies they can feed the children, those kind of issues they don't know. Even IYCF, we have extensively done IYCF practices evaluation. At district level, we have done even 8 states, all districts, more than 150 districts we have evaluated. And there are some very shocking news coming from even this dietary intakes and even complementary, initiation of complementary feeding practices, and especially the quality of diet. The quality of diet also not good, because adequacy diet. So adequacy diet, even NFHS survey shows that only 6% of children are eating adequacy of diet. So not only adequacy, and another issue is we are also discussing with the dietary diversity, very poor in dietary diversity. Suppose we have 10 food groups are there. Out of 10 food groups, every person should eat at least daily 8 food groups out of 10 food groups. But in rural area, we observed only most of the people are eating only 4 food groups and 4 to 5 food groups only. In urban area, 6 to 7 food groups. But even in urban area also, the adequate diet and the dietary diversity achieved only 24% of the population. Recently, we have sent for publication these things. So in that case, because for control of undernutrition, control of hidden hunger, and control of NCDs, we have several programs are there. Even national programs are available. So we need not start a new program, but our programs are well designed and objectives are well targeted. But only we are failing in implementation, coverage, and some of the programs we are not even reaching to the public. And the public, they may not knowing what are the programs are available and what are the inputs we can get from those programs, those issues also there. So then there is a lot of need in a program awareness, creation of program awareness. What are the programs are there? What are the beneficiaries? Who are the beneficiaries? And what benefit we can get? And if you are coming to the obesity, but here only the obesity, I already told you, it is a vicious cycle. It is starting with from birth itself.
Dr. Lakshmi, yes, I would like to take forward the discussion, from your point about, I think the large of the, mostly the problems which you are highlighted are kindly being attributed towards the unawareness and lack of, awareness or literacy around nutrition. So let me go to Ravi on this. And Ravi, you have been, leading some of the, I think a very, very impactful awareness campaigns, activities, behavioral change. And I think, the triple burden which Dr. Lakshmaya is highlighting, malnutrition, undernutrition, and then, the hidden hunger and that ever-growing NCD burden in our country. And all three are being connected with the wrong food habits. And the wrong food habits is being connected with the lack of awareness. Illiteracy, as Dr. Lakshmaya said, that even the literate are illiterate. How you see, as a communication professional, as a public affairs professional, and somebody who has been working on this area, how do you achieve this outcome where you can really make some behavioral changes? And I see that you are very, very enthusiastic, about technology, role of AI and multiple other things. How do we use them and actually make the impact, make the behavioral changes?
First of all, thank you, Kamal, and thanks to IHW for calling me to this particular very interesting discussion. And I'm very proud to be associated with you guys, because the kind of work you guys put together is of next level. Now I have heard Dr. Khera, I have heard two other speakers also. It's amazing the way the discussion is flowing. I have certain points which I would like to add before I reply to your particular question, Kamalji. The first thing is, a lot of data is all quantitative data which is available. A lot of data is absolute in nature. There's a lot of data every day when things happen. There needs to be some systems. People talk about the HMIS, people talk about NFHS, people talk about census, people talk about other surveys, etc., etc. That's purely cool. They should all go in. What's more important is basically when was the last ethnography done with the communities who are really, really at the bottom of pyramid on the nutrition outcomes? When was the last ethnography done? When did the anthropologists last visited these communities and came out with certain suggestions and recommendations? It all happens at a very, very small level, at the project level, when someone invests the money from the CSR kitty, or some international grants are given to NGOs like XYZ, will not name the NGOs. So India is a country, if I tell you, which has various countries inside India. Like, why I'm saying this, UP itself is equal to UK in terms of size and everything. In terms of population, it's 3 times more. But the problems which are there in UP or Bihar, like you have the Musars, you have the rat eaters, you have the Mahadalits there. What's happening to the nutrition outcomes there? What are the pathways to reach there? Is it only food? Is it only nutrition supplements, or it's only nutrition which will help? Or there are some aided, interventions, like wash interventions, like interventions like food diversity on intake of food. Then the food consumption habits. What's happening in India on migration? A lot of people in the tribal regions migrate from one place to another. So for around 3 to 4 months, they get some services from the frontline health workers, either from the NGOs or from the civil society. But the interventions don't have the broader vision, which is source and destination. If an intervention is happening with the mothers at one place where she is there right now, a lot of them migrate also. Where is the intervention on the source and migration? When I particularly see the policies of last decade, means last 10 years, there are sudden changes which happens in the policies. There's sudden things which gets introduced. It's good also. Things should move on, like we move on in life. So policies also move on in life. And there are very interesting people, on this panel who were talking about food diversity, etc., etc. But I would also like to bring something on table about the culture. What's happening on the culture front? Why carbohydrates are getting more used and less of protein and less of other things? So you go to the villages, they are growing millets, they are growing ragi, they are growing wheat, they are growing jawar, they are growing many other things. But when you see the consumption patterns in many places, especially in the tribal areas I'm talking, so they have maize, they dry the maize, they consume the maize throughout the year. When you ask them what is happening to the millets, why you are not consuming them? They say isme zyada paisa milta hai, so this is for selling. So and many other things. Then I personally think, like, marketers like us or marketers like others needs to be super responsible. What we are doing with the young generation, what we are doing with the kids, what we are doing with the moms. So some brands of biscuits are reaching to the last mile. Some so-called uh, immunomodulators are reaching to the villages last mile in terms of some food supplements and other things to the moms. When you see the amount of sugar in that, it is so alarming to see, like, a country like India, which is the diabetic capital, where we are saying, like, you consume this and you will be fighting against COVID, you will be having better, your body mass index, you will be able to deliver better. So there are so much myths and misconceptions where in the last mile populations, the last quintile populations, where basic food is not getting available, where take home ration from the government is not getting available, there a packet of small biscuit, I will not name it, it's available there. And you see the consumption pattern. Daily, a child eats around 2 to 3. I have seen it myself. And you see moms, so one dabba after another dabba, people are, the marketers are making them hooked to take that. What is happening to the lactation, policy? Like, are we very strong on lactation? So lactation is an art. So are our frontline health workers trained enough on lactation? It is the counseling. You need particular type of counseling on the latching. How latching is to be done. Yeah.
Ravi, how are you achieving this all in the project which you are doing?
Yeah. So I'm coming to that, Kamal, now.
Yeah.
So it's very interesting to have various things, like, the two mechanisms what we have set. One is the artificial intelligence and second is the blockchain. Blockchain we use to ascertain the results. Are the results fudged or results are true? If someone says, I am able to save a child's life who was Sam, means severely malnourished, he has moved from Sam to ma'am to now normal. So what is the journey? So the whole blockchain mechanism actually ascertain the results for us. That's the first part. Second is the AI part. So still, like, a lot of work happens on the manuals, on the records, on the reportings. So, like, you have the image sensing techniques to see, like, when you put the sensors on the face, you can actually see, like, how much pain your body is going through. There are technologies like that. So we are working on the AI technology to ascertain, like, which all pockets are the hotspots, like, so that the intervention is designed on the hotspots more, and all the level of efforts goes there. It should not be an intervention where you are just doing the Jan Jagruti. I totally understand. It should be a public movement, but the first focus is to basically save the kids who will be dying if you don't intervene. So this AI has helped us, Kamalji, for reducing the referral time. Like, today, a child is being diagnosed, like child has SAM. So it takes to reach around the nutrition rehabilitation center 14 to 15 days to reach. And that period is a very, very big period. From that 14 to 15 days period in the geographies where we are working, we have reduced that time to 2 days. And 2021 for us, it will be, in less than 1 day. We should be able to do the referrals. So we have put up the voucher schemes. We have the vouchers in place. So those vouchers are conditional vouchers, and all through, e-money transfers, which takes care of transportation of, kid, which also, because there are certain levels you have to take the kid to certain times. And this whole, our national programs focus on, moms to be there with the kid in the nutrition rehabilitation center. When we talk about family, when we talk about parenting is not just an issue of mom. There is a role of father also. So if a child has to be admitted in the nutrition rehabilitation center for 14 days or 15 days, the parents, it's a joint responsibility. Mother also needs, psychological balance, moral support, financial support, and many other things. So we enable men's participation in the program, so that when the kid is admitted in the nutrition rehabilitation centers or getting referral, father has enough money to travel with the kid and the mom. On the top of that, then, there is a very interesting point on the M-Narega. So what is happening, like, when your kid is admitted for 14-15 days, you tend to be with the kid. So there is a loss of job. You don't have the money, because I'm purely talking about the last quintile population here. So making sure they have the money when they are getting the treatment done for the 14 days. And after the child comes home, after treatment completion, we see like, we follow up every month rigorously. And there are community nutrition workers who just don't speak Marathi or Hindi. They speak the tribal dialect like Pavadi and Bhil and others, so that there is a less, communication deficit, and we touch the social norms, the values, as well as, the subcultures. And our whole program is designed on the basis of behavioral change communication by identifying the behavioral nudges. Where when we started at Kamalji, a big part of the technology came in place, where we had the ethnographers staying in the community for a period of 6 months before we designed the program. And then this technology comes into play. This is my submission.
Thank you so much for highlighting this point. And the most remarkable thing which you are saying, that with the technology you are able to actually escalate the children to the rehabilitation center faster. Now, I would like to actually, I was keeping Dr. Atreja, up at 1 a.m. in the morning. So, Dr. Atreja, you have now heard almost every aspect of Indian nutrition saga. And from so many policies to 3 kind of hunger to the burden, and then also somebody highlighting so strongly the role of technology. You are bringing some technologies and you are trying to bring in some kind of intervention for women and child health in the country, in India. And you are seeing it from the New York, and then from the most of the technologies are at your disposal. How do you see a solution for this problem with the role of technology?
Thank you so much. Kamal, first, I want to really thank you for having me here. And then also, I've just really enjoyed, this is probably one of the most productive 1 hour time at 1 a.m. that I've done over the last many years. And really learning a lot, and also allowing me to come back to my roots. I was telling Jagmeet Madan that I worked with Anup Mishra and learned a lot from him when I was at AIMS, and I learned a lot from public health, and that led me to come to US to do masters in public health and really look at a system-based approach how we can address problems. And one of the things which I found the gap in public health was, how do you scale the delivery of the programs? There's so many, and Dr. Lakshmi actually just hit it in the nail. They say we have so much science and we have so much well-thought programs, but how do you deliver that was a challenge which I was struggling since 2000. And once I started doing my residency in US, I spent 2 years building and coding and doing data science work from 2002 to 2004. And that led me to see that informatics, IT, and digital health can be the biggest source for empowerment and delivery of programs. And I'll talk about that example, how that addresses this. So for the last 8 years, my focus exclusively has been on digital health as a scalable solution to deliver the science of what is learned in healthcare. And the reason for that is the major gap in healthcare delivery is it is locked with space and time. What I mean by that is, ultimately the care is delivered to through frontline health workers, through clinicians, through nutritionists. But they have limited time to talk to each person. Think about each of the clinicians we have in India. How much time they have to impart nutrition education or awareness to the people that comes to them. In 5 minutes, they have to give a medicine. They don't even have time to do that. And the second part, which Dr. Khera mentioned so much, is lack of awareness. How much of the knowledge, the pre-diabetic population knowledge, or the programs clinicians have or frontline health workers have, right? So how about we create a program, a digital program, which takes the best knowledge that is there, and at the click of a button, any healthcare worker can give it to the patient, right? And not only give it once, but actually can remind them and follow them, right? And, Ravi Bhatnagar actually mentioned very nicely about, we also need to have a precision-based approach, because we have 2 different kind of patient population. One is from obesity and others, and the other is from undernutrition, and sometimes it's combined. So we also need a precision-based approach to know who the person is. So just 2 days ago, Amazon came with Amazon Hello wearable device and an app where you can actually get your body mass assessment just through a 3D picture, right? So you can, at a zero cost, without any device, learn the basic metabolic pattern of a person. And what is best is you can prescribe an app to thousands and millions of people, to nearly all US population for free, right? So that's where you combine digital health as a way to deliver public health program to masses through clinicians and others. And I'm very proud of the initiative we just got started through RX Health Arch Network, partnering with Diwakar Clinic, Dr. Hema Diwakar, who is, I think, a 2-day force in delivering care through the artist program. So we partnered and created a digital health program for COVID and for pregnancy. And with a click of a button, we reached out to 3,000 people, women. Many of them were pregnant, and many of them were women who actually were in the pre-pregnancy or pro-pregnancy stage, and taught them how to be safe during pregnancy, and actually gave a prescription of an app which talks about what to do for nutrition and other health for first. Many of you and actually create a very indigenous Indian version of that and empower that and scale that program through artists and others to millions of patients as well. And then assess the benefit by doing a text-based survey to say, first, has it improved their awareness? And secondly, has that improved their action and behavioral change? Right? One is to empower awareness. If I tell my patient, the other is to actually assess the behavioral change in them, and then have a separate kind of a motivational intervention which can happen through AI. If a person has not made a behavioral change, is it because they have not understood it? Is it not because we're not governed in their language? Or is it because they need a nudge from a nutritionist? They need that specific phone call, right? And you can have an assessment and automate that part and have a chat-based option to motivate them. So we're also talking to CureFit, talking to Goki. How do we actually create a new kind of extenders for healthcare, which could be counselors, which can chat and democratize that channel. So you don't have to necessarily come to a visit with a clinician. Clinicians can come to you in your home, right? So these are some of the initiatives, but I know Dr. Hema Diwakar may be on the call as well. We really want to touch from 3,000 people to 1 million people, pregnant females. And we cannot do it alone. We can only do it together. And so just want to kind of anchor that sentiment in that regard.
Thank you so much, Dr. Assis, for highlighting. And I'm sure with the technology intervention you are talking about, we can reach to a large number of society, population, and at least to the caregivers. I would just like to take because now we are running out of time, so I'm so sorry, but I will not be able to take the comments from all of the people. But let me since I began with Dr. Ajay Khera. Dr. Khera, you have seen that, and in your experience of public health handling the nutritional deficiency, and now we are talking about blockchain technologies, apps, and then the wearables, and getting 3D, BMIs, and so many things. Do you think that these are going to help when it comes to solving this problem of malnutrition among our children, women, which we are struggling for last 74 years or 73 years now as an independent country? Dr. Khera, you are on mute, sir.
I think what you said is really very critical, and we must make best use of the available technology. Whether, as Dr. Bhatnagar spoke about something in terms of referring the children to the the rehabilitation centers at a very short duration, because he said around 2 weeks are taken. But if you use the power of technology, you can make those referrals easier. And similarly, when Ashish was talking about the role of digital technology. I mean, that is also relevant, and particularly for a country like India, where we have a huge population, where there are challenges of access of healthcare, and where it is not possible to provide, specialist doctors to the remotest part of the country. I think the way forward is the digital technology, and we must make use of it appropriately.
Thank you so much, Dr. Khera. So with this, I would like to, close our inaugural session, and just to sum up that the challenges which we as a country we are facing are immense. The numbers you have been hearing from the entire 1 hour of this session, that we are grappling with a big problem, serious problem, and it is a kind of national emergency to take care of. But there are, the new ways of handling it. As Dr. Khera said, we need an out-of-box thinking to address it, and how Dr. Madan and Dr. Lakshmaya highlighted that how with the right kind of understanding and behavioral change and nudges, we are going to make that difference and achieve these ambitious progress when it comes to reducing the number of or the prevalence of malnutrition, undernutrition, anemia, and so on, which is ailing our population, which is wonderfully young. We have the highest number of children in our country, in the world, who are also going to be the young adults, and going to join the productive population of our nation, and going to fuel and propel this country to become the the superpower which we all try to, or dream of reaching to.